We'll talk about cardiovascular sounds today. So yesterday we talked about lung sounds and pointed out that turbulence is really the source of the sounds that you hear in your chest. And that density, we don't really talk about how modulus really changes the sound, but we'll talk more about that with ultrasound. But density changes the sound, changes the frequency, amplitude, and somewhat the duration of the sound. And so we're moving through the parts of the physical exam. Today we're going to talk about the blood pressure and the cardiovascular exam. First we're going to start talking about carotid bruits, talk about blood pressure and heart sounds. So your carotid, it's the big blood vessel in your neck that feeds your brain. You've got some other blood vessels in the back by your spine that go to your brain too, but the carotids are the big main vessels. They come almost straight off from the big vessel, your aorta. Your aorta comes out of your heart, the big tube that feeds the rest of your body from your heart. Comes out of your heart, and there's two carotid vessels that come almost directly off to feed your brain. Because your brain is the most oxygen-dependent part of your body. I mean, it needs a lot of oxygen, it needs a lot of blood. And so that's reflected with how well it's fed from the heart. And so your carotids come up, and as people age, they can develop plaques and build up in your arteries. So we talk about that with the heart a lot, but it happens in other vessels as well, including the carotid arteries. And so you call it carotid stenosis if the carotids start narrowing. So stenosis just means a narrowing. It's Latin derived, I guess, for a narrowing. Stenosis if something narrows. And so you can imagine if your carotids are narrowing, you get less blood to your brain. That's not a good thing, right? So more critically is that plaques can break off. And the carotids are right below your brain. So what happens to the plaques that break off and get into your blood? Stroke. Gets in your brain, clogs the artery in your brain, and that part of the brain dies. Not a good thing. So we don't like carotid stenosis. And so part of the physical exam when you have older patients is to listen to the carotids. And what you're listening to is turbulence caused by narrowing. And so you start hearing turbulence when the carotid is about 40% closed. So and then you'll hear it until it's about 90% closed. But more than 90%, you don't hear turbulence anymore. Why is that? Well, they're not quite dead necessarily, but there's not really enough flow going through now. There's not enough blood pressure to push the blood through the vessel. I think I have seen a patient that had at least a history of 100% occlusion on one carotid, but yet, like I said, you have two blood vessels in the back of your brain as well. So the flow being totally off doesn't necessarily kill you. The big concern is that's a lot of plaque that can break off and cause a stroke. And so that's an issue. So what does that sound like? What is the turbulence? So this is actually a pretty straightforward auditory finding. It's not as complicated as the lung with all the air that surrounds the lung and all the things I was talking about yesterday. This is pretty straightforward. This is just turbulence. You'll recognize it. The only thing that's kind of unique is that it pulsates, right? So that's not the one I want to show. Sorry, that wasn't right. It pulsates. The sound pulsates because your blood pressure pulsates because your heart's beating. You know what? I just don't have it ready. It will sound similar to. I'll have to find it later, guys. Sorry. I'm never ready. But it kind of whooshes. That's what you hear when you hear turbulence and beat with the heart strides and so forth. So that's carotid bruits. Why do I talk about that before blood pressure? You'll see. So we want to talk about measuring blood pressure. This guy named Stephen Hales, he was a clergyman slash scientist slash jack of all trades. This is kind of what people with money in Britain did in the 1700s, I guess. They just kind of dabbled in everything. But one of the things he dabbled in was the cardiovascular system. He made wax models of animals' hearts, and was actually one of the first people to talk about heart valves. And he kind of understood the concept of what heart valves did. And we'll talk more about heart valves. But one of the things he did was he measured blood pressure in animals. Not in the most humane way, I guess, but he would take the animal and take its carotid artery and put a pipe in it and let the blood pressure raise. And he measured the blood pressure of course, like this, for example, measured at 8 feet. Actually, I've kind of seen that. When I started med school on our parents' farm, we had a cow that went down after giving birth. It was an older cow, it had like 10 pregnancies, and over time, mammals can lose enough calcium through pregnancies, and not supplementing enough, that the cow, after the pregnancy, didn't have enough calcium in its body, and calcium is used to signal muscle contraction. And so it couldn't really move. That's why it was down on the ground. It couldn't move because it didn't have enough calcium to get the muscles contract correctly. And that also affects breathing. Its heart was still going okay, but it started to labor breathing because the diaphragm's a big muscle and it wasn't moving the lungs. And so we had a vet come in, and the vet right there on the ground, like, poked a big old hole in the jugular and like dropped in an IV to give it some potassium and calcium. You can kind of do that with animals because I guess they don't get air emboli like humans do. But anyway, so that horse was alive when that was happening, I'm sure, because that's how you maintain blood pressure, because the heart has to keep beating. If the heart stops beating, you don't maintain the blood pressure. So, Stephen Hales, blood pressure, but obviously that's not a great way to measure blood pressure in people, right? That would not be fun.
Come on, you can chain somebody to the ground and stick a tube in their neck.
Yeah, I don't think that happens very often.
Can't do it with animals anymore with pets.
As well as you don't want to poke a hole in the carotid. I mentioned poking a hole in the cow's jugular. That's a vein. And in humans, we do poke holes in jugulars. I can talk about that later in class in the hospital, controlled environments. But in animals, apparently horses, this is not uncommon for jugulars in horses. The Mongolians would, like, as they're riding the horse, would sometimes lean over and nick the jugular of the horse's jugular and drink from it. They lived from the horses, they never did the horses. And the horses seem to tolerate it. It's a big kill horse. So anyway, blood pressure, sorry. Lots of stories about that. So physicians started getting an idea that blood pressure is kind of important, and they wanted to know what it was about, not putting holes in carotids. This guy, this Frenchman, Pierre Propane, he came up with taking just a ball and pressing it against your radial artery, the one that you take pulses from, that one right there. He would just take a ball and press it there, and it was hooked up with a manometer. And he would push on the ball until the pulse stopped. So you can see he's measuring the pulse right here. That's downstream from the heart, right? And he's pushing on the ball. And he's pushing on the ball until the pulse stops, which means he's occluded the artery. So he's put enough pressure on the ball that the blood pressure can't push through anymore, right? So that is the pressure of the blood. When you equilibrate, the blood doesn't flow. And so that's what he's measuring right there. This manometer is measuring the pressure that he's pushing on the ball, but that's also the pressure that the ball is exerting on the blood vessel. Does that make sense? So that was like the first way to actually measure blood pressure without pouring someone's blood out with a big tube. It wasn't the best way to do it, so I don't know how many people have tried to feel pulses and wrists, but it can vary from person to person. It's sometimes hard to find. Also, you got issues with how you're pushing on it and so on. And so his student, an Italian, Scipione Ricci, later in the century, invented what became known as the sphygmometer, which sphygmos is pulse in Greek. And so manometer, kilometer, pressure gauge, that's all it's saying, it's blood pressure. That's all, it's a fancy word for some concept. And he decided, I'm not going to mess with the rest, I'm going to mess with the brachial artery right here, which is, it divides into the radial artery down there. But the brachial artery is right here at the tip, like kind of in the tip of your elbow. You can feel your biceps tendon right there, and then kind of right by it, you find a pulse. That's what he thought was easier to measure. The other benefit of that is, think about the location right here. Where's this close to? Your heart. It's close to the same level of the heart, whereas your wrist could be anywhere if you hold it in different places. So you want to measure the pressure at your heart level because that's what your heart is working at, and that's kind of the best way to correlate, because a big person, small person, there's lots of variation with regards to how far from the heart you could be measured for different people. So try to measure blood pressure at the same height as your heart. So what he did is he basically took a tourniquet, created a tourniquet from bicycle tubing, and wrapped it around the person's arm, and he tightened it until, or he inflated it until the pressure was great enough to occlude the brachial artery, and he couldn't feel pulse anymore. So same concept, he was just using a different way to inflate something to, or he's finding a different way to block the artery and find that pressure, at the maximum pressure that the artery can exert before the maximum pressure that the artery exerts. So it would have been lost in history maybe, but Harvey Cushing was one of the big guys at Johns Hopkins when Johns Hopkins was starting to become the institution for medical knowledge. And he happened to visit the institution that this guy worked at in Italy and saw what he was doing, liked it, took it back to Johns Hopkins, and the rest is history. Signor Ricci may have played around with the mercury a little too much because he apparently died with neurological complications that made mercury poisoning. So we don't really like mercury, which is why we don't. It's advised against using mercury, even though it's technically the gold standard for the manometers for blood pressure. But in daily practice, we don't use mercury in the hospitals or clinics. So that's the inventor of the sphygmomanometer and a schematic of what he made. His mercury manometer there and the bicycle tubing. Pretty straightforward. It's essentially not that different than what we use today. So before I show you what we use today, one last thing, because we don't actually measure, we kind of measure the point of when the artery gets occluded, but nowadays we're being a little more sophisticated and we're looking for a range. So you know blood pressure has two numbers? You ever notice that? I don't know how many people have seen the blood pressure measured. But there's two numbers. There's a top number and then a slash and then another number. Sometimes they're written above another. The top number is the higher pressure, and that is in millimeters of mercury. That's the pressure unit that we're using. So usually that's not written out by the physician. They just say like 120 instead of 120 millimeters of mercury. I don't know what I said before, but it's millimeters of mercury. The bottom number is the top number is called the systolic pressure. We'll talk about systole and diastole later. The bottom number is the diastolic pressure. And that's essentially the lowest pressure that your blood maintains when the heart's not contracting. So the top numbers, so it's a range. So it's the range of pressures that your cardiac system sees. So the highest and the kind of lowest that it sees. And so the way that we learned to measure the lowest came from this Russian guy. He was just I think he was an army surgeon in Russia, but he was doing some experiments on dogs. Again, doing experiments on animals was a little bit easier to do back then. People didn't have the same ethical issues that we deal with today. But apparently he was playing around, and he wasn't planning to study anything about blood pressure, but he happened to have a stethoscope out when he put a tourniquet on a dog's limb. And he noticed as he had the stethoscope on the dog's limb that he started hearing some sounds. And so what do you think he was hearing? He was listening to the blood vessel that he was putting the tourniquet on. He started to hear the pulse causing turbulence in the constricted blood vessel. So he had the tourniquet on, not so much that it occluded the artery, he had it sort of partially occluded the artery, and he was creating turbulence. And so these sounds that he was hearing was that I was describing with carotid bruise, but they're not from carotid stenosis because of the plaque buildup, rather they're from a artificial stenosis created by the tourniquet that he put on the dog's limb. So if you think of it, the sounds start when, so if you have the tourniquet on too tight, it's like having 100% or 90% stenosis of the carotid artery. You don't hear anything, right? There's no flow going to the vessel because the tourniquet has too much pressure on it and no blood goes through. So you don't hear any sounds when you got the tourniquet on too tight. As you start to loosen the tourniquet and decrease the pressure that you're exerting on the blood vessel starts to open up. And when it starts opening up, blood flows through and you start hearing turbulence. And so you start hearing the heartbeat reflected in that turbulent sound. So you start hearing. And as you gradually decrease the pressure in your tourniquet and loosen it up, eventually you get to the point where the blood pressure is great enough that it distends the blood vessel to the point where there's no more turbulence. And at that point is that low number, the range, the diastolic pressure. Make sense? So I can demonstrate. That's a picture of Korsakoff's sphygmomanometer. And I'll demonstrate with a video. This I have ready. So pass around a couple sphygmomanometers. So this is the bladder or the tourniquet. All right. And it gets wrapped around your arm. Who's never had their blood pressure measured? Okay, then I will not explain the whole process. You get the idea. Wrapped around the arm, the clinician holds the manometer in their hands, and they take this pump. Here, right now, the pump is open, so it's not inflating the bladder. You close it, and you start pumping up the bladder. See that? And so, if that's constrained around someone's arm, that's going to start exerting pressure on the arm, right? So you pump it up, and as you pump it up, the gauge will reflect the pressure. Right now, you don't see anything because there's no resistance on the bladder. If I put an arm in there, you would start seeing the gauge go up. And so, most people's blood pressure is under, well, usual healthy people, a lot of times the clinician will only pump it up to like 140 millimeters of mercury. If you're not really sure how healthy the person is, or you know they have a history of hypertension, which is high blood pressure, pump it up to like 160 or 180 just because you know it's going to be up there. But that gets kind of tight. So if you know it's not going to be up there, you don't usually go up there. There's procedures for this that are recommended by professional societies. I'm not going to go through that. So you pump it all the way up, and then once it's up there, you take your dial again, and if you're good, you can do it all with one hand. You open it up, and the pressure will cause air to come out, and the gauge will start drifting down. As it drifts down, what you do, you have this on your arm, you have your stethoscope. You know what a stethoscope is? You have a stethoscope sitting right over the brachial artery. And as the pressure decreases, you start hearing the sounds, the Korsakoff sounds, and you keep listening until the Korsakoff sounds go away. So you record, and you're looking at the dial. So you're looking at the dial, and you record when you first start hearing sounds, and you record the number when you stop hearing sounds. So when you start hearing the sounds, that's systolic pressure. When you stop hearing the sounds, that's diastolic pressure. That's the standard way that people do it for a long time. There's electronic ways to do it, which just measure pressure variations. This is the standard way. You pass around, screw around with these. You have a question?
Is the reason you don't catch it on the way up because the noise from inflation? Is that
yeah, it's kind of noisy.
You get it on the way down because you're bleeding the air out.
Yeah, there's that. Actually, the video I was going to show you, actually, I'm starting after they inflated because the inflation's kind of noisy and I didn't want to confuse you, and that's exactly your point. There's also a little bit of, I remember some discussion about the issues about how the corticoff sounds here when you occlude the artery as versus is when you release the occlusion. The standard is to occlude first and then release.
Is the diastolic pressure is its purpose an indication of occlusion and versus absolute blood pressure? Is that why you're getting two? What medical information do you get that's distinct from the two measurements?
Now you're asking about what the standard state of the art is over the years. It used to be diastolic pressure people cared a lot about because they thought that was like the baseline pressure. Because that's kind of, in a way, that's kind of like the default pressure. If the heart skipped a beat, you'd still always have that diastolic pressure. It's kind of the baseline, constant background pressure that your whole body sees. And people kind of focused on that up through the 70s, maybe even, there's still even today, people still kind of talk about it. But right now, so as cardiologists may argue with me on this because they're more sophisticated on this, but right now, the general basic practice, like a general practitioner, they would kind of not really care so much about the diastolic pressure. They might talk about it a little bit with older people because you start having what's called they start caring about the difference. So you can start having a widened pulse pressure, like the difference between systolic and diastolic starts widening as you age, and that's because, it's a little bit beyond what I was going to talk about, the aorta stiffens as you get older. And in a way, the aorta is dampens blood pressure because it stretches. So it's the first thing that the blood hits coming out of the heart. And so it kind of stretches a little bit and it dampens that initial wave from the heart. As you get older, that damping effect decreases, and so that's reflected in people's systolic pressure kind of goes higher and their diastolic pressure goes lower. And so you see that more in elderly, so sometimes people care about that in a clinical setting, but usually they don't care so much about diastolic. I care more about hearing what the systolic pressure is, because it's kind of the difference of caring what the baseline is versus what's the worst possible scenario. The worst possible scenario is when you get a really big, strong pulse from your heart, and you get 180 to 200 millimeters of mercury hitting a blood vessel in the brain. It's kind of weak, and then you probably weak, you know. Or if you have a leak of a blood vessel anywhere in the body, like you've got your aortic can actually, your abdomen, as you age, can kind of start stretching. You don't want that to leak either. So that's going to be dependent more on what the maximum pressure is. So systolic pressure tends to be what people focus on. Long answer for a decent question, a good question, but wasn't really what I planned on. So anyway, we care about blood pressure. We also care when blood pressure is too low. And that probably is what people cared about more in the age before antibiotics. Or this is kind of turning into the age of the antibiotics. This is like the cusp of it. Antibiotics didn't really start out, didn't really become part of medicine mainstream. I'll say it this way. People tried to kill bacteria with medications in this time period, in the 1890s to 1920s, but it really wasn't effective until penicillin was developed. And then suddenly people said, hey, we can cure fever. We can actually cure infection instead of like just kind of holding their hands as they got it. And when you have a really bad infection by a lot of bacteria, your blood pressure plummets. And so that's why blood pressure is one of the critical things to monitor when someone's sick. When your blood pressure is too low, your brain doesn't get oxygen, and you die. That's one of the things that happen. Your heart, and kidneys, and liver, they all have problems. Anyway, that was a long aside for what I was going to show you. So this is what the dial looks like. You've got the blood, the pressure cuff inflated. Up to, they took it up to almost 160, and now they're releasing the pressure, and what we're hearing is the sound from the stethoscope. So those louder sounds are just background noise, so they're hitting a microphone. But that's just pumping it up again, coming down. Right there. Sounds like it's disappearing, but there's one more little sound attacks. But yeah, you also can see the gauge jerking. You notice that? That's the heart beating and causing a temporary rise of the pressure. Yeah.
So it seems kind of like prone to inaccuracy.
Oh,
looking at the
yeah.
gauge. So yeah, I'm assuming the tolerance is okay in medical practice, or is it an issue of, I mean, is there critical information that you may, is this again like a screening criteria for a more invasive or expensive analysis?
I mentioned gold standard at some point. The actual gold standard for blood pressure is to put a catheter in through one of the main vessels down to the heart and measuring blood pressure there. And that's pretty invasive. Cardiologists will do it, but on the bedside you're not going to do it. So yeah, you're right. There is variation. If there's, what you do is you do it to get a rough idea. If it's weird and or you have clinical reasons to suspect that the number's off, then you do it again. And if you still are concerned, you get a different device to use. I'm going to pass around this. So this is a little home thing that people buy to measure blood pressure. And it's actually, actually goes on your wrist. It's a radio. Something like that. You're supposed to hold it at heart level. Turn it on. That'll measure blood pressure. So it's inflated. So anyway, pass it around. Feel free to play with it. It'll make a little noise, but everyone knows it's going to care. Make a little noise. Those are kind of notorious in the medical world, the electronic versions, for having inaccuracy. So, but they're usually what is used in the hospital by the tech who goes around measuring blood pressure. And so, as a physician, when I was an intern, I would look at the number, and if I thought it was off, I would go measure it myself. Or I'd get one of these to go measure it. We wouldn't send someone to the cath lab to go get the gold standard from the cardiologist, but we would measure a couple times. The other thing that you're supposed to do technically that you never see in general practice, unless you got a very thorough doctor or they have a reason to think they should, technically you're supposed to measure both arms. Because theoretically, you could have an occlusion or some kind of vascular problem in one side of your body, and it would not be discovered if you didn't look at both arms and see if there's a difference, right? So, and then if you start thinking about what if you have perfusion problems with the blood vessels in your legs are bad? Well, you wouldn't find that out if you're measuring the arms. So if you but you're not, that's not really the standard of what you're supposed to do when you get blood pressure. But if you have suspicion of someone having vascular problems in their feet, for example, you measure blood pressure in the leg, you compare that to what you get in the arm, and we call that the ankle brachial index, ABI. And you can compare whether or not they're really perfusing their feet well or not. So yeah, there's a lot of things that are gray. It's not hard and fast like you'd like to be. But with practice, you start getting a sense of when you need to care to recheck. So that's blood pressure. Let's talk about heart sounds. And so for that, we need to talk a little bit about the anatomy of the heart. So let's talk about the heart. So let's take the view, we're going to start as if we're a blood cell leaving the lungs. Just recently been in the lungs and got reoxygenated, okay? So the blood comes from the lungs into the heart by way of pulmonary veins. Technically, veins are not blue or red like they're colored, but rather veins, by definition, are vessels that could return to the heart or return blood to the heart. So the pulmonary veins actually carry oxygenated blood, but they're returning to the heart, coming from the lungs. So they come to the heart and they go into the left atrium. So the oxygenated blood is coming from the lungs to the pulmonary veins to the left atrium. That's the atrium or an atrium is the front room. You go into like a Greek villa, the atrium is like the foyer, you know. So the atrium or atria of the heart, there's two atria and two ventricles. That's the foyer, the first chamber before going to the second part. So there's 4 chambers of the heart, left, so it's left and right, and then top and bottom and away, atrium and ventricles. So the blood comes from the lungs, goes into the left atrium, where the left atrium's job is to fill the left ventricle. And the left ventricle's job is to contract and drive blood up into the aorta, to the rest of the body. It goes to the whole body and comes up through the, you see down at the bottom it says inferior vena cava. The vena cava is the venous analog to the aorta. So the aorta leaves the heart, comes around, and then divides in all these branches, go deliver blood to the whole body, and then the vena cava collects all the branches of all the veins together and brings the blood back up to the heart. And it has, so you have the blood come up through the vena cava back to the heart, goes into the right atrium, which contracts, puts blood into the right ventricle, that contracts and sends blood through the pulmonary arteries away from the heart, deoxygenated blood to the lungs. Be reoxygenated, come back to the pulmonary veins, the left atrium again, and so on. So the critical thing for our discussion today is you have valves. Like any pump, you have valves between the chambers. So between the atrium and the ventricle, the left atrium and the left ventricle, you have the mitral valve. You see that written there? You see all this right here? It's this funky valve that kind of looks like this and goes like that. Has these tendons essentially that pull it down. These are the muscles as the heart's contracting. These muscles contract and pull it down and close it. So it's like going. And then there's a valve between the left ventricle and the aorta, called the aortic valve, right here. Right here it looks like it's bicuspid, but there's actually 3 cusps in most people, and some people there's like 2% of the population, there's 2 cusps. So they're bicuspid. That's what it looks like in cross section. That's the aortic valve. And that's the valve that closes after the ventricle contracts, sends blood up in the aorta, and it contracts to keep blood from backflowing. Or it closes to keep blood from backflowing. And that's the point when the aorta kind of stretches a little bit and kind of modulates that peak pressure from the heart. Dampens it a little bit. So all the blood goes to the body, comes back to the right atrium, and now between the right atrium and the right ventricle, you have their tricuspid valve right here. And then you have, in the big pulmonary arteries, you have the pulmonic valve right there. So you have these 4 major valves of the heart. And you have blood flow changing abruptly when these valves open and close. So that makes noise. And so that's what the physicians are listening to when they come up and start putting a stethoscope on your chest. They put it in different spots. I don't know if you've ever noticed that. They put it in different spots. They're not just listening for your pulse. Because, I mean, I can tell if you have a pulse. I can grab your wrist and feel your pulse. I don't need a stethoscope on your heart to tell me that your heart's beating necessarily. But how your heart's beating, I can tell, I can learn a lot by listening to how the different valves sound. So, so we listen to your heart, and admittedly it's somewhat difficult. For one thing, we tend to hear best in 1,000 to 5,000 hertz, which is what typically the pitches of voice is. You know, it makes sense that we evolved hearing to match what we speak at, right? But the pitches of the heart are a little bit lower than that. Typically like less than 500 hertz. You have 60 beats per minute, and every time your heart has a cardiac cycle, that's a beat. So 60 times a minute, you've got 4 valves opening and closing. 60 times a minute. So you got 4 sounds within about a second to listen to as a physician. So each second you easily can have, well, not really 4 sounds because because the right side and left side usually or mostly contract at the same time. So I'm not really going to talk about the right valves very much. I'm going to talk about the left valves because that's the bigger side of the heart. That kind of dominates the sounds. And for this purpose of this class, I'm going to talk about the aortic valve and mitral valve. So really, there's like two sounds, and you can hear that. You know, you've heard people talk about going bump bump, that heart sound. Bump, 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 bump. Those are the two sounds that you're getting. You can have more sounds than that, but we're going to focus on those two basic sounds. We were talking about this yesterday about recognizing sounds. There's a reason. Part of the reason that we say medical practice is you learn to recognize these kind of gray things that you can't quantitate sometimes through lots of practice. And it's like learning pitch. Actually, there's a study that just came out about learning pitch for musical pitch. Like supposedly there's people out there who have perfect pitch, right? And it's kind of, people just kind of go, oh, you're just kind of born with it. Well, there's a study recently that suggested that that's not really true. It's definitely trainable. And that's, I can attest to personal practice, it is something trainable to recognize heart sounds. But you have to do it a lot. Interns easily listen to 10 different patients' hearts in a given day. And most months when I was an intern, I only had 4 days off a month. So I was in the hospital all the other days of the month. So that's a lot of different hearts to listen to. When I say 10, you could easily go up to 20 another day. I'm saying at least 10 a day. So you get a fair amount of practice listening to sounds. And the way medical practice goes is you're comparing your experience with the experience of other people. These patients in the medical teaching hospitals aren't being seen by just the intern. They're seen by the intern's senior resident. They're seen by the attending physician. Nurses listen to the heart. I mean, the patients get examined by 5 different people on a given day, and often multiple times in that day too. So, and then those people that examine an individual patient go talk about what they heard, and so you learn from that. So it's a little bit different type of education than engineering, where there's hard, fast facts that you kind of learn about. You learn the basic concepts, and then you extrapolate into all these different examples that you get exposed to as an engineer. In medicine, you have to kind of see all the examples first, and then from that, extrapolate the basic understanding. And sometimes it's hard for you to explain how you know what sound corresponds with what disease. You just kind of know because that's what you learn. It's more like learning a language. A lot of times when you learn a language, you know something sounds right, you know you're supposed to say it this way, and if you were asked why you're supposed to do that, you're like, well, I think there's some grammatical rule for that, but I say it this way because it sounds right, right? That's often what happens after you practice medicine. That's why it starts to sound. So, kind of went through the cardiac cycle. What I should point out is, so the atrioventricular valves, those are the valves between the atrium and the ventricles, obviously. The semilunar valves are the ones that lead, or where the blood leaves the ventricles. And so, the first sound, that lub dub sound that I was talking about, that first sound, the lub, we call it S1 in medicine. And that's the sound caused by the valves between the atrium and the ventricle closing. The atrium contracts, sends blood into the ventricle, and when it fills up the ventricle, the valve closes, and that's the lung. And then the ventricle contracts and squeezes blood into the aorta or the pulmonary artery. And as the semilunar valves close, blood decelerates in a way. It's not technically, the sound doesn't technically come from the valve closing, it's indirectly coming from that. So that's the two sounds that we're basically hearing. So the lub dub is because of these two sets of valves. Let me demonstrate that with another. So blood's in the atrium, coming to the ventricle, coming out of the ventricle. That's the aorta up there. Lub, dub. Lub, dub. Make sense? don't actually listen to those sounds over the exact site of where the valves are, because of the acoustics, because of the anatomy of your body, the sounds actually sound stronger at different spots. The sounds reflect in different areas of the heart more in preferential ways. So this is the location of the 4 valves I talked about. But when you listen, you can hear them more strongly at these locations. So you hear the mitral valve most strongly down here at the apex of the heart. This is where the largest part of the heart is, the left ventricle, and the sound comes from the mitral valve down here at this spot most strongly. You hear the tricuspid most strongly right here. It's kind of right by the xiphoid process, or where the end of your sternum is. Up here after your second rib, so you count down a little bit, you got the clavicle right under your first rib and your second rib. You've got, on your right side, you can hear more strongly the aortic valve. On the other side, you can hear more strongly the pulmonary valve. You listen to these different spots to see if you hear sounds that indicate that the valves aren't working right. And so there's, we want to talk about, that's just a description we use. We want to talk about murmurs. So there's other sounds, I'm not going to go into it, it gets kind of complicated, and even amongst physicians they kind of discuss where these sounds come from. But the murmurs make a lot of sense on an engineering level, because we've been talking about turbulence making sound. So what these murmurs are is they're similar to the carotid bruit. In fact, it's really synonymous. And I say bruit, some people may say bruit. In North America, apparently, no, I've always heard bruit, but apparently you can say bruit. Anyway, bruits are for peripheral arteries. So in carotids, you might hear a bruit, like in another part of your body for whatever reasons. But it's the same thing as a murmur, it's just turbulence. And so what causes turbulence in some of these major valves? I'm only going to talk about the left-sided valves because they're the strong ones that you tend to hear. You don't hear the right ones as easily. I'm not going to worry about that because the concepts are still the same. For you guys, it's more about the concept. So what causes turbulence to cause sound that you can hear? And you can have abnormal size. So if you're the aortic root, or the part of the aorta that joins up with the heart, it can kind of get stretched out. And so that size can cause a change in velocity. So you come from the heart and all of a sudden it's wider, the vessel's wider, then suddenly the velocity can suddenly change. That causes sound. If the valve has a weird shape or a sharp edge, it can cause turbulence. That causes a sound. If you're anemic, it can cause your blood viscosity to change, to lower, because your blood viscosity is determined by the proteins and fats in your blood and by the red blood cells. Less red blood cells means you're anemic and you have lower viscosity, which, if you remember the Reynolds number, the viscosity is on the bottom of the Reynolds number. And the Reynolds number is the number goes up, that means there's more turbulence. So viscosity decreases, the number goes up, more turbulence. Healthy people sometimes will get what we call a physiologic murmur that doesn't mean anything health-wise, which means that their heart's strong enough to beat hard enough to sometimes cause the velocity to go fast enough to cause a murmur. But in general, the louder you can hear a murmur, the louder the murmur, the more likely that there's a problem. So I'm going to talk about 4 common ones at the aortic valve and at the mitral valve. Again, the aortic valve is the main valve that leaves the heart, goes into the aorta. The mitral valve is the valve between the left side, the left atrium, and the left ventricle, which are the main ones that send blood to the rest of the body. So stenosis, we talked about carotid stenosis. Stenosis is a narrowing. So you can have a congenital aortic stenosis. People are just born that way. About 2% of the population, their aortic valves kind of smaller than average. As you get older, they can kind of degenerate. There's calcifications that can kind of build up and kind of close down the aortic valve, make it more narrow. And so you get more turbulence as blood passes flow. It gets to the point in about 2% of adults, it gets so small that they need a valve. Used to be that we got a lot of inflammatory causes of aortic stenosis because rheumatic fever, was more common. We've kind of got that under control since the advent of antibiotics, but like one of my grandparents, my grandfather, my mom's dad, he had rheumatic fever, and one of the sequelae down the road after you had the fever when you're like a kid, it can cause inflammation in your valve and cause problems like this. Mitral stenosis, very similar things to happen. It's also more commonly a site of bacterial infection. You can have bacteria start living on your mitral valve, and you can imagine put a bunch of foreign gunk on a valve, it's going to cause the blood flow. You can also have a myxoma, which is a type of tumor that can grow from that spot, and it's kind of random that it can appear there. Aortic regurgitation. So regurgitation is different than stenosis. So stenosis is narrowing. Regurgitation happens when the valve isn't patent anymore, for whatever reasons it leaks. And so after it closes, it doesn't close all the way, and you get backflow. So the aorta may stretch out a little bit when it initially gets the surge from the heart, but then there's kind of backflow, and it pushes blood through the incompetent valve back into the heart. And that backflow you can hear. Same thing can happen when you have the ventricle contracting. If the mitral valve isn't closed all the way, but contract the valve blood back into the atrium. And so you can hear that. So with the aortic regurgitation, a lot of similar causes. Mostly it's caused from this congenital bicuspid aortic valve I mentioned earlier. A lot of people, I mean, this isn't necessarily a public record, but a lot of people think that's the cause they are. Arnold Schwarzenegger became a politician because he had to get a new valve. They think because the theory is that he had a bicuspid valve. That's the most likely explanation. And he got a mechanical valve. And if you have a mechanical valve as opposed to a bioprosthetic, mechanical valves, blood will want to scab over. It wants to clot on. You don't want clots because they eventually come from the heart and go up your brain and cause a stroke. And so he has to be on a blood thinner. Well, if you're on a blood thinner, it's kind of hard to be very vigorous as a weight. So one of the theories out there about why he went to politics and left the job of taking the shirt off, plus age. Mitral regurgitation, similar issue. There's a lot of people who have what's called a mitral valve prolapse. The reason that the mitral valve doesn't close all the way is because it kind of involutes. It like turns inside out a little bit. So I have videos and sounds of all those. We go through that, and that will be it for the day. So aortic stenosis. That's what it sounds like. So the second beat is where the valve closes, right? The second beat is where the aortic valve closes. So when the valve's open and the atrium's and it's pushing blood out, that's where you're getting this turbulence. So instead of this is the normal sound. Kind of noticeable, right? And so just hearing that sound, you can, and especially if you hear it up here, as opposed to other places that you listen, but also just the basics of that sound, to a trained physician, they go, oh, they've got aortic stenosis. That's something we need to think about, because if it gets down to less than about 50% of the cross-sectional area, then this person may need to do a valve. And if it gets too bad, you need to start talking about how long they have left to live. So it's a pretty important valve to have problem. Mitral stenosis. There we go. No? No, it sounds right. And now we have aortic regurgitation. So in this case, they have a little bit of stenosis causing this sound, but after the valve closes, this is the second sound, the dub. After the aortic valve closes, you're getting backflow into the ventricle. And so you're getting turbulent sound after the valve closes.
What's the red line on these
Yeah.
videos?
So they're graphing out this up here. So you can see on the neck this pulsation.
So it's like an amplitude of
Yeah.
like the movement.
Well, it's technically, they're saying it's the pressure. If you can somehow put a pressure gauge in there, that's what they're saying it is. And there's sophisticated diagnosis that you can get. So this is microregurgitation. So again, the mitral valve is closing here at S1, but it doesn't close all the way until you get backflow during systole. Systole is, no, we don't get that. Let's get that. Questions? This is a summary. Let's turn that on. That's a summary. You can graph out how the sounds kind of sound, and so doctors learn this kind of stuff to kind of graphically represent what they're hearing. So that kind of ends my lectures on turbulence and sound. We'll talk more a little about sound when we talk about ultrasound. We're getting close to being done with the physical exam techniques, the low tech. Start getting into my, got maybe one more lecture of low tech and then the higher tech.
Let me just say,